Another one in the series, Israel is Alive and Kicking, with Professor Eyal Leshem of Sheba Hospital, who will give us a report from the front line of fighting the coronavirus. Today is Holocaust Memorial Day in Israel, so on behalf of all of us here, we convey our sympathy with the Holocaust survivors, most of whom are separated today from their families, and we wish them good health and speedy reunion with their loved ones. Professor Eyal Leshem is the director of the Center for Travel Medicine and Tropical Diseases at Sheba Medical Center and a clinical associate professor in Tel Aviv University School of Medicine. In addition, Professor Leshem is a guest researcher at the Center for Disease Control and Prevention, CDC, in Atlanta, and a consultant to the World Health Organization. Professor Leshem, thanks for joining us. I want to thank Yoel Arev of Sheba Hospital for facilitating this webinar. And Professor Leshem, we are way into the crisis, but can you tell us something about the nature of this coronavirus and how different it is from others?
I think the main two topics that we came to understand since this virus was first described are, A, it is highly contagious. So we know how it's transmitted between persons, and it's transmitted between a person to person through close contact, mostly either contact with respiratory secretions or simply contact with an infected person. And the second thing, and we know approximately how infectious it is. There is a measure that many of you must have heard of that's called the R0, which is the number of persons that are infected from each patient. And it's an epidemiologic measure. Some patients will infect less persons and some will infect many. They are called super spreaders, but the average is called R0. This virus has an R0 that is at least twice that of your garden type seasonal flu. The other thing that we've came to learn that is that older persons and persons with chronic illnesses tend to develop a very severe illness. Sheba Medical Center, for those of you not familiar, is the largest in the Middle East, considered one of the best hospitals in the world and defined by Newsweek as one of the 10 best hospitals. We have nearly 2,000 patient beds and 1,000 physicians. It's huge by any measure. And we've treated the most COVID patients compared with other hospitals in Israel. For example, we now have 30 severe patients who are on mechanical ventilations. This compares with the total number of ventilated patients in the other two hospitals in near Tel Aviv. Ichilov and Rabin Medical Center have less than what we have in our medical center. So we've learned a lot about this virus. These are severe patients. I was in charge of the secondary intensive care unit of COVID the last weekend. And we treat 10 ventilated patients, but it demands the full attention of one of the best internal medicine teams in Israel that is used to treating 40 patients in internal medicine. We treat 10 patients and we are stretched to the top. So my personal lesson here, everybody talks about the number of mechanical ventilation machines, but simply taking a box and saying, here's a mechanical ventilator, treat a patient, that won't save many lives. The burden of treatment that is needed to save these patients, some of them are younger, 40, 50-year-olds. The burden of medical expertise needed to save these patients is very high. And it just gives me a little bit more of a reasoning to develop this discussion about how careful we need when we when we do reopen the closures and social distancing. Over.
You because you said this virus is so contagious, you're a great supporter of social distancing, right?
Well, I am not, this is not like a political science and you don't support or object. Social distancing is a tried and tested tool of public health used since at least the 13th century, or the 14th century, the Black Death, where they invented the quarantine and social distancing. It is clear that when you have an outbreak of a disease that transmitted from a person to person, when you reduce the number of contacts between persons, the disease transmission will decline. We know from the Spanish flu that cities and towns that closed their schools had much less morbidity and mortality. We know this across ages and between diseases. The only problem is that there are no free meals in life, and generally, and neither are in medicine. And the cost of social distancing is very high. So we cannot look at social distancing as one package. A good way for me to simplify this is if you say there are 10 million citizens in Israel, and each one citizen meets another person 10 times daily, 10 different people you meet daily. So you have 100, I'm not a mathematician, this may be flawed, but it gives a ballpark, like back of the envelope calculation. 100 million encounters with the possibility of transmission, okay? 10 million, 10 encounters. Now, close schools, you have all these 40 kids sitting together in kindergartens, you drop to 60 million. You close workplaces, you drop to 40 million. You close public transportation, malls and so on, you're down to 15 million. You're already down to 15% of all encounters. Now let's say the trick is gonna be open less encounters, but more benefit, kind of a Pareto principle 20-80. Open a little bit more, but make sure these are the highest impact. That's how social distancing should probably function. And you have to do that with a very close eye on disease surveillance, on the number of cases and on the number of severe cases.
I don't want to upset you by all means, but a few days ago we hosted Professor Eyal Leshem, who opposes this approach, and he says that the coronavirus causes less death than the flu in average year, and there will be more people who will die because of the collateral effects, like being closed at home, not working, etc. What is your take on this?
My take is as follows. As a physician treating patients, I can tell you that if there was no social distancing, we probably would have lost. So Sheba may have 500 ventilation machines and beds, but many of these 500 would not have survived. So the burden on the medical system would be terrible if we had completely did not use any social distancing. I fully agree with Professor Leshem that if the Israeli economy pays $500 million a week of closure, these $500 million we are going to miss this money when we plan ahead to build hospitals, to pay for physicians and nurses and new drugs and cancer therapy. And here we shift from medicine to economy. And we know even in medicine, Israel has 400 million shekels every year to update the national health insurance law, services included in new technologies. We get 400 million, and we have to choose. This is a societal choice, not a medical choice. We have to choose between new therapy for, say, breast cancer that will add so-and-so years, and new therapy for colon cancer. We can't have both because we don't have budget. I agree with Professor Leshem. If we shut down the economy and we become a poorer country with a lower GDP and a lower tax income, we will not be able to afford health down the road. So this decision of how much we can pay medically right now in lives and in life year lost, and how much it's going to cost us in 5 and 10 years has to be taken into account when deciding about social distancing and closure measures.
You think the coronavirus experience will stay with us for a longer time, even when the virus is gone, like wearing masks, like in the Far East, these kind of things?
So, for the second part of the question, I don't think the virus is going to go anywhere. Certainly not within the next year to 18 months, because we can't anticipate having a vaccine before next spring or summer of 2021. Some people are more optimistic and some are less, but realistically, this virus doesn't seem to be going anywhere. Now people, the mankind is an adaptive species. So we will have to adapt to some new behaviors. Same as after 9/11, we adapted to standing in lines in every airport and every mall. We will adapt to taking temperature at the entrance to malls, working places, do a lot of telework, perhaps telemedicine, perhaps some less closer person-to-person contacts, more of a Scandinavian type or Indian without a lot of hugging and kissing. These are all behavioral changes that some of them may stay for a long run.
The question, how do you estimate the time needed to allow families to reunite?
I think, pending Israel Ministry of Health instructions, there is a safe way for, first disclosure, I have not seen my parents in many weeks, probably since Purim. But from what we know about this virus, I can see my patients at a 4 or 5 meters distance. If I wear a mask and I'm feeling well, and we sit outside in a park, and they have washed their hands, and my parents are in their late 70s, early 80s. They have washed their hands and put on their masks and have not touched their face. So this virus doesn't float in the air. It could either come from a very close contact with me if I'm a patient. I could be not symptomatic, so there's a risk. But if I put a mask and they are 3 meters away, the risk is negligible, as long as they kept their behavioral conditions. So we kind of differentiate between what can be done. I could see them tomorrow. What's instructed by a Ministry of Health. Ministry of Health is still afraid and would not let them go out. And understanding there is a risk because people inadvertently do touch their face, not used to masks, and at some very specific conditions, this virus is very transmissible.
There's a question, does Sheba has enough equipment you need in all fronts, like the ventilators, the masks, the equipment for the medical staff?
So going back to what we talked earlier, what Sheba has done is incredible in my eyes, and perhaps Yoel can share some either figures or data more than I can. In the fact that we shifted from about 100 intensive care unit beds to capacity for 600 ventilated patients. And this was done over a period of less than 6 weeks. We have several underground parking lots that have infrastructure for normal hospitalization, not intensive care. They simply have the oxygen lines and the communication lines and electricity run because we were afraid of rocket attack. So in case of rocket attack, we can hospitalize people in underground shelter. These were transformed into fully equipped intensive care units with nearly 600 beds overall in 2 underground shelters and 1 hospital and 1 outpatient within less than 6 weeks. So we have equipment. However, we will not be able to treat our we have 7 internal medicine units at Sheba Medical Center that see thousands of patients every year. We have 4 now invested, quote unquote, in COVID patients, and only 3 treat internal medicine patients. We know every winter these 7 units function at 140% capacity. We cannot do all. So there are 2 lessons here. One, Israel, compared with other OECD countries, has one of the lowest rates of acute hospitalization beds per 1,000 population. We are at 1.8. If you look at OECD data, you will see 3, but this includes rehabilitation and geriatric beds. Our acute beds are 1.8. So Israeli medical system is incredibly efficient. We spend very little on health from our GDP. I think half of what the US spends, and we generate incredible value. But this system has no reserve whatsoever. Every winter we do very poorly, and next winter we will not be able. So the long term, we always prepare for the next war. So the first long term lesson is we have to increase capacity in healthcare, because the cost coming winter is going to be incredible if we have another wave of COVID parallel with flu. And the second lesson is, even if we have 600 beds, just treating 8 patients consumes a full internal medicine unit. The 600 patients will not survive even if they have a ventilator. So we won't have an ethical dilemma whether or not to ventilate, but they will not survive. These patients, once they're on ventilator, are very complicated, and I doubt if many of them will survive. So I think there was a whole discussion about the mechanical ventilators, and I was asked once, and I said, we may have ventilators, but we don't have enough doctors, nurses, skilled teams to treat these patients. So the machine itself is not enough. Over.
You mentioned the second wave. How likely it is that we're going to have a second wave of the coronavirus?
It's highly likely that we will see an increase in 1 to 2 weeks. The severe cases will show up in 2 weeks to 21 days because we increase the number of person-to-person contact. The big question is how high is this increase is going to be and how manageable it's going to be parallel with our day-to-day medicine. Keep in mind, Sheba continues oncology, cardiology. We transplanted a heart 2 weeks ago to a 40-something-year-old woman who was more than a year on cardiac support because her heart was not available. It's very difficult to do both. And here we left medicine and we go to governance. The government will have to decide. We either take the price of, we may have mortality among risk population when the number of cases increases, and mortality on non-COVID patients. What we call indirect mortality from an outbreak is mortality from heart attack because we couldn't do the catheterization. We were, or we didn't have a good bed in internal medicine for them. We're ready to pay this price because we cannot function anymore as an economy.
You think the Ministry of Health exaggerated or put the public in panic?
The Ministry of, when you ask the Ministry of how do you say Misrad HaBitachon?
Ministry of Defense.
Yeah, you ask them how much are you willing to pay for a Qassam not to fall in Sderot, even if it scratches a car. They will say, we pay, I don't know, $1 million Kippat Barzel, $250K Kippat Barzel to make sure it doesn't scratch a car.
Iron Dome missile.
Okay, Iron Dome. That's a societal decision. It may not be cost effective. It may be cheaper to buy chemotherapy, but that's a societal decision. So the Ministry of Defense, their decision is no Qassam on Sderot, we use Iron Dome, no matter what it costs. It's exactly the same for me as a doctor, and for that sense, for the Ministry of Health. We do not want anyone to die from COVID. We are doctors. From here on, it goes up to society, government, and parliament. They have to make a priority. And we are, you cannot ignore this. One way to look at it is called life years lost. Life years lost means one death is never one death. It's how many life years we lost. So for example, if you have a very debilitated 90-year-old, cognitive decline, very low, very short life expectancy, who dies of a terrible disease like COVID, it is not the same as a 30-year-old driving his car on a two-lane road that costs 300 million to make it double and safe and gets a head-on crash. So when we say making all roads safe, making one road like this safe, red road, we know on a red road we have 10 deaths every year. I can say in 2021, 2022, I will have 10 young people die from car crashes in this junction until I do an interchange. And the interchange costs 500 million shekels. I know what's the price. I don't immediately pay it. I can say this is planned for 2025. So the cost is not necessarily, maybe, I hope my train of thought was not lost, but the price you pay for a life has to be weighed on a life year lost. And it's not the same to save a life of a 30-year-old, which may cost so and so, and to save a life of a 90-year-old. Now, this is very difficult to communicate, but it's something that our government does every day. They test the effectiveness and the cost effectiveness of interventions. And again, me as a doctor, when I'm treating a patient, I never look at the cost of treatment because I swore the Hippocratic oath to save everyone. I do whatever it takes to save, but a society must, in a very knowledgeable and data-driven, evidence-driven way, look at the cost of life lost, not as one life equals one, but as how many life, and not necessarily longevity, but what we call quality adjusted life years or disability adjusted life years. And these are commonly used terms in scientific and in professional observation of the cost of interventions. You have to measure the cost in life years lost, not as one life.
You mentioned that all these decisions have to be based on scientific knowledge, and there's a lot of talk about the tests, but lack of tests, the tests are not quick enough, etc. But the real tests are serological tests, no? These are the ones.
They test different things. The PCR is the test that's taken from the nose and throat, tests for a RNA of the virus. It tests whether or not the virus is present in secretions. So when you have the fever, you want the PCR used. The advantage is, if it's positive, we are sure you have the virus right now. No doubt about it, very specific. The shortcoming is it's not very sensitive. If you're negative, doesn't mean you don't have COVID now. About 20 to 30% of COVID patients test negative. So the implications are, even if you're negative, you still have to be isolated. If you have respiratory fevers or respiratory symptoms of fever. That's one test, that's the PCR. The other one, the serology, tests for antibodies. That tells you if your immune system reacted to the virus. This could have happened 1 week ago, 1 month ago, or 1 year ago. So if you're positive in serology, we know you've seen the virus. We don't necessarily know when this happened. Could have happened right now, and we have some ways to interpret to know if it happened in the recent period or if it happened long ago. It's different antibodies, but in reality, they are used differently. The serology, the antibodies are used to know about the person if they've seen the virus, so to speak, if they were infected. And on the community level, what was the infection rate? We may go to Bnei Brak, a city of 200,000 people now, do a serologic survey and find out 70% were infected. For 100,000 infections we had only in Bnei Brak. If we do a good survey, we may find that out. And it will tell us the virus is not that severe because Bnei Brak is a young population. Haredi Jews, Orthodox Jews have many kids. It's a young population. They were all infected. They are now, we had 100,000 infections and we only had 100 people ventilated. Many of them not from Bnei Brak. So the way to learn about the epidemiology of the virus, what's the mortality, what's the severe morbidity is by serology, a population-based serology. The PCR is the only way to say if a certain person is infected right now.
There's a question, are you in contact with any of your Chinese counterpart? Do you get any information, any assistance from China?
Yes, what the Chinese have been doing the last few weeks is they have used their success in slowing down the outbreak in a campaign of talks between doctors that worked in Wuhan. Many of them have excellent English and went to the US for a fellowship. And they have been teaching other doctors around the world what they did in a successful way. Much of what they talk about is not based on on robust scientific evidence, unfortunately. When you read the Chinese papers, many of them would not be published or considered for publication if this was on any other disease. So I would take much of what comes out of China with a grain of salt. But I think they use it strategically. China is a superpower in context of global domination, and seeing the United States crumbling under the weight of this outbreak, they want to help the Americans, they want to help the Italians and the Israelis combat this disease, and they're doing it by teaching us in webinars, by sending us textbooks, by publishing papers and sending aid. However, again, with a grain of salt, some of it is reasonable evidence. Much of the published data is what we call case series and would not be published on any other circumstances.
Okay, so before wrapping up, the last question, how do you foresee the race for the cure? And then, of course, for the vaccine, what is the state of the research right now?
So we are, I must say, I am regarding medication. You've seen the best research institutes in the world try and utilize a number of medications on this disease, and I've not seen one good study showing a highly effective drug. There was not one yet. It is a surrogate to say we don't.
What about Kaletra or
Kaletra? So Kaletra is lopinavir, ritonavir is an HIV drug that was tried and was not effective on a study published in the New England. Other drugs were tried, were so far published as case series, as small studies with non-rigorous evidence. I know the Americans, the NIH is performing a study in Nebraska in a biologic containment unit, and they are comparing the antiviral remdesivir to placebo. Now, they've been doing this for over a month now, and they've had several dozens of patients. If they would see a very dramatic response, the Data Safety Monitoring Board would have discontinued the study and published. Not having seen a publication is a surrogate to me that we may not still have a very effective treatment. So disregarding the cure, and we are more modest in medicine, we don't cure. Sometimes we have, a slight improvement in chances of surviving. That would be excellent. But this was not yet shown in a very good study. We are still anxious to see. Vaccine, the same. There are more than 40 candidate molecules of all types of vaccines, RNA vaccine, DNA, live attenuated, killed virus, subunits, and so on. All those will have to undergo safety testing because vaccines have to be safe. Then testing in lab animals, animal models, safety testing, then 2A phase 2 testing in humans. And one complication is we're always afraid the vaccine we give will cause antibody immune enhancement, will actually make the disease worse. So we'll have to be very careful in evaluating and moving forward with the understanding that vaccine is really the answer for this disease. Not simple at all. So cure is simplific. We would hope we'll find a new balance. We don't really, many ask me, when are we gonna beat Corona? Well, you don't beat nature. If you ever swam against a tidal current, you can't swim against it, but you can learn how to live with it and how to manage it. And that would be a more cautious or humble approach.
On this happy note, Professor Eyal Leshem, thank you so much for a wonderful session. Thank you, Yoel Areven, for facilitating it. Anybody who wants to be in touch with Yoel, we'll give you all the contacts. Stay tuned to our next webinar tomorrow at 11 a.m. We'll host Shai Doron and his team from the Jerusalem Foundation, who will update us on what has been done for the vulnerable communities in Jerusalem. Thank you all for being with us. See you soon. Bye-bye.